Okay, now we get to the last session of the day, which is probably among the most interesting ones that we'll have. It's my pleasure to introduce Bill Thies. Bill is a researcher at Microsoft Research. He finished his PhD at MIT, and we are very fortunate that he decided to continue his life further in this part of the world. He's been associated with Microsoft Research India for many, many years. He briefly went back to Boston for some time, but we are very glad to know that Bill is now back in India and will soon be again part of Microsoft Research India. Bill has done some pioneering work. If you just look up the term 99 dots, you'll see some very, very impressive stuff that Bill and the team at the lab did in the area of tuberculosis medication. So we are very happy to have Bill moderating the session, and I'll leave it up to Bill to introduce his equally impressive panelists for the last session of the day. Bill?
Thank you very much, Satish. It's great to be here today with all of you, and I'm thrilled that we have a chance to discuss applications in a very high-stakes area of healthcare that affects all of us very personally and is, very newsworthy topic these days as companies and researchers and everyone is gathering more and more data about our health and using that both to benefit us and also potentially carrying some risks with those benefits. Today we'll talk not only about health in our own lives, but also the social kind of applications of health in environments like India, where you see in rural areas still a big health disparity to access and benefits from health services. We have a very interdisciplinary panel today representing technologists, also social scientists from a business perspective, from an academic perspective. And I'd really welcome all of you to think about your hardest questions for this team. I'll get it started and eventually open it up to the audience. So with that, why don't we get started? I'd like to I'll call our panelists one at a time to join me on the stage. First today we have Dr. Beena Thomas. If Beena, you could come up. Beena is until recently was the deputy director of the National Institute for Research in Tuberculosis, or NIRT, which is a very well-regarded, influential center for research in TB based in Chennai. And there she was also the head of department in social and behavioral research there. And Beena is just a very influential voice for the TB program. We also do some work with technology and tuberculosis. And her publications and research and studies there have just been enormously influential in pointing the direction of the TB program, where she's the staunch advocate for patients. So we'll see a user-centered perspective. I'd also like to invite Dr. Rahul Panicker to the stage. Rahul is the Chief Innovations Officer at Wadhwani AI. Wadhwani AI, for those of you that haven't heard, is a new nonprofit research institute focusing on AI for social good in environments such as India. Rahul is trained in machine learning. He got his PhD from Stanford and subsequently did a social enterprise called Embrace, where he was co-founder and president, where they produced infant warmers, among other things, for over 300,000 babies in India and other countries. So thank you very much, Rahul, for joining us on short notice today. Finally, I'd like to introduce Dr. Greg Moore. Greg is the corporate vice president at Microsoft of Health Technology and Alliances. He is trained as an engineer, as a physician, and as a neuroradiologist, so interdisciplinary in one person here. Previously, he's worked elsewhere, was previously at Google. I've heard of that company as well. He's taught at Stanford. He's led innovations for big health systems like at Geisinger. And he's also very passionate about extending the benefits of health into underserved communities and has volunteered extensively in low-resource areas. So we really have a very special panel today, as you can see, and thank you again all for joining us. So why don't we get started? So Beena, I'd like to start with you. You spend a lot of time researching stigmatized diseases like TB and HIV in India. Can you help us understand, from the patient's perspective, someone who's just been diagnosed with tuberculosis, let's say, what are they thinking about privacy? What does their privacy in that context mean to them? And what could it cost them if that privacy was compromised? How do you approach patients with that view?
Thanks for the question, Bill. And yes, it is sad, like our previous speaker was talking about. In India, somehow this whole question of privacy is compromised because people don't realize they have the right to privacy. So in overcrowded clinics, you find that there's a diagnosis made loud and clear that everybody can hear it. And the patient goes back totally disillusioned. You don't know whether he would come back again because of the way the privacy or confidentiality is not maintained. And this is something that we have found because we did an amazing study on pre-treatment loss to follow-up, and we found that almost 22% we had lost because they did not understand what this meant, just that they went back shamed that they were diagnosed with TB.
Very good, very interesting. Thank you for that perspective. We'll come back to some of those themes in just a moment. For now, I'd like to go ahead for Rahul. Can you?
Yeah.
Okay. You have multiple mics. Very good. Could you tell us a little bit, Rahul, about the work you're doing in healthcare and kind of how that opens up new challenges from your perspective in privacy and security?
Sure. Yeah. So we're a non-profit research institute doing AI for social good, and one of the large areas we work in is healthcare. We have work going on in maternal and child health and in tuberculosis, and beginning some work in eye health. Quick examples to actually ground this conversation in maternal health. One of the things we're doing is the world. There's a lot of low birth weight babies born world over. About roughly 30% of India's babies are low birth weight world over. About 20 million of them, and we're missing too many of them. The global health world has tried. We're sending out spring balances with frontline health workers for the last 15 years or so. Hasn't worked. Magically, for example, a large number of India's babies weigh exactly 2.5 kilograms, and that's because that's the cutoff for low birth weight. So what we are doing is, meanwhile, mHealth solutions have been deployed, digital pipelines have been laid that track pregnant mothers from pregnancy all the way through early childhood. And what we're doing is actually a visual weighing machine where frontline health workers, like ASHA workers or ANMs or Anganwadi workers, on their generic Android phone can take a short video of the baby, and even in the absence of network connectivity, we can estimate the baby's weight. And we do this with, since most of you are technical folks here, we do this with learned deformable models. It turns out that realistic babies exist in a low-dimensional, baby shapes exist in a low-dimensional space. They exist in a roughly 90-dimensional space, even though you need about 7,000 vertices to represent them. So we do this, and what this provides is a barometer for newborn health, and you get a dashboard showing where your low birth weight babies are that no longer involves someone punching in numbers. Another bit of work we're doing in tuberculosis is on predicting adherence, because in the absence of, and this is, we have the experts here. In the absence of proper adherence, what you have drug-resistant TB developing. So, are there ways to predict who is at risk of non-adherence so that preemptive action can be taken? Because each frontline TB health worker, a TB health visitor, is overloaded, and they see anything between a few hundred patients to sometimes a couple thousand. Those are. We're also working on things like predicting a pregnancy risk and so on. Those are some areas we work in. As you can imagine, these are very sensitive topics. So, for example, whether someone has TB or not, there's a lot of social stigma associated with that. What's the sensitivity to a health worker coming into your home and actually taking a video of your baby? Right? Should one be, how worried should one be of what happens with that data? What sort of data should be stored in the cloud, and what should be deleted right on the phone once it's been processed? This influences our machine learning models. For example, all the models we built are built to be light enough after compression so that inference can be done on the phone. So at the bare minimum, you can just give inference at that local level and in fact transmit the inference, which might be just the weight at a bare minimum without the video ever reaching the cloud. You can also go one step further and have this mesh model that cannot be recognized as a specific baby. Or you can have this 20 numbers that form an eigenspace representation, okay, which again cannot be uniquely traced back to an individual baby. So there are various ways in which, apart from the standard ways of privately preserving AI, that can be applied. Right? I think technology has a role to play in, so this is not binary basically. There are technological tools that can be applied to do useful things while preserving privacy. And There is, of course, a trade-off between privacy and utility, but that frontier can be pushed with technology.
So, yeah, there's some interesting ideas. So isolating the most sensitive data to the point of capture and not exposing it further than those people would want.
Point of capture, actually sandboxing it within the application itself, so that it's never, for example, saved into the camera roll of the phone. Right? There are all kinds of things depending on how low you go in the stack.
Thank you. And Graham, I'm going to bring you in just a minute, but I already an overlap here, Beena, for things we were discussing earlier, which is the questions that we ask patients. Sometimes we get different responses depending on their perception of how private that data would become. Could you maybe just educate us as an audience in terms of, for example, when we're asking for contact information or phone numbers for people that have very stigmatized conditions, how that can sometimes be represented differently depending on their how they see that data being protected?
I would like to just digress a little bit. One of the things that I want to, because our whole platform is about digital technology, one is, yes, the kind of socially desirable responses that we get from our patients. But what I would like to bring to the table here is this relationship that we've had with Bill and Microsoft and the BMGF. While even designing a technology, how important it is to consider the perspectives of patients, like in terms of the information that they give you, in terms of how this technology works. So I was just listening to some of the previous talks where even in developing a technology, how important it is to understand what patients' perspectives are. I think that is something, like whether they're willing to share, they give you fake telephone numbers, or they give you telephone numbers which do not belong to them because all they want is treatment. So while we did this, it's really amazing. First of all, I would really like to compliment Bill, like the way he was introduced today, that he's the man of 99 dots. And this is something that, it's a chorus that is being sung all over, about how important it is not just to go by socially desirable responses of patients, self-reports, but to have something that is more tangible to be able to find out whether they adhere to treatment. So what was good about it is that they asked for a validation. So that's the challenge that I want to ask many of the digital technologists here. Do you really have, a validation done of your technology? And that's where we came in. And we did a validation, and we found, like he said, that a lot of responses were false positive or false negative, more false negative. The reason is because we have nearly not gone to them to find out what they think. So they would give you they would say, yes, we will call you, but then they don't have a phone. So it's like some of the things where we found they would take the medication but not call because they did not possess a phone. Or my daughter has a phone, I gave her number, I took the medicine, but she did not call. She was at work, she was too busy. You look at another technology which we looked at is technology to do with MERM, where we just decide what goes. It's like a top-bottom approach sometimes. You give them this huge box with all the medication, they don't even have a place to store it. So some of the things they did was to store it even in a hen cage, or away from what people thought. So what I'm trying to say is, when we think of stigma issues, the need to involve them even while we come out with the technology is so important. And every time we did this validation, we would get across to Bill and his team and say, it can be strengthened. This is what we need to do. And there was this dialogue that went back and forth. And I think that is what's important in understanding what patients feel about it. There was one again where we had this alarm. You open the box and there's an alarm. So they said, my God, the neighbors can hear it. So what they would do is keep the box open and keep some A4 papers there so that, the box remains open. So there are many things that I think, the need to validate a technology, the need to involve, have a community participatory approach, and here it's the patients, to be able to understand what they want, what they need, even before we come out with the technology. And then this constant feedback from patients, on what they think about the technology. Because I really think, my personal opinion is, this technology is awesome and it has a lot of, potential. But if we don't have a health system which delivers it well, so there are so many players here. So it's not the question of just taking phone numbers. It's not the question of just listening to, socially desirable responses, but to put all this together and come out with something that really works. Because I read a beautiful thing on WhatsApp saying education was to shift from thumb impression to signatures. Are we shifting back from just signatures to thumb impression with digital technology? All you need is for them to, use their impressions to get across to technology.
Thank you for that perspective. And we were talking earlier, actually, with your team that there was a patient diagnosed with HIV and was asked to give their address,
Yes.
but they didn't want to do that, so they gave the address and the name of a neighborhood dog. And when the health workers visited, they were led dutifully to that person who was not who they were expecting. So all those things are subtle things that come out. I'd like to bring this conversation out to you, Greg. So we've heard some of the challenges that can come up. I'd like you to take some time, 5 minutes or so, and say, how does Microsoft approach this question? You're deeply involved in the kind of the cloud support for health data and have to be very sensitive to the privacy and security concerns. What can a big company offer in this space?
Sure. Thanks for the question, Bill. Just thanks so much for bringing this topic to the symposium. I traveled here to India from Davos at the World Economic Forum, and in addition to the environment, data and privacy and even healthcare was right at the top of the issues that the world's trying to grasp with. So this is really, really timely. I'll say something controversial to start.
Please.
So technology companies have not earned the trust to handle patient data. So we haven't earned it yet. If you think of, I've grown up in academic and integrated healthcare systems, and these are institutions in their community, not only in the US, but around the world, that have been around for hundreds or even 100 or more years, and they work to earn that trust every single day with their patients by giving them effective care and showing up there every day and handling that with trust. So my view for Microsoft and what I would, Microsoft's view and what I'd like to see the entire big tech industry adopt is the custodianship of that data remains with the healthcare system or the entities that patient is trusts and associated with. When that data is under the custodianship tech can bring tools to those institutions to do big data, to do analytics there to enable and empower them. And in the very special circumstances when they need help from a data scientist or machine learning scientist, there's no shortcut there. Go through the standard processes that we have at universities, through internal review boards, IRBs, and actually embed them in the institution, bring them there rather than bringing data the other way. So there's mechanisms to do this, and to do this with transparency and trust going forward. I guess the other way that I would respond, I would love to see, and these are the principles that I talk to our engineers in Redmond in healthcare going forward, is to adopt some of the things that I as a physician adopted in medicine, but now I think that we as tech should adopt as we're engineers and technologists dealing with healthcare data. We, as a physician, first do no harm, and I think adopting that principle as we think about engineering and technology as applies to data, and even a quote that stuck into my mind was from William Mayo, one of the brothers who founded Mayo Clinic, and said the patient's best interest is the only interest that matters. And if you apply those two principles in how we treat data, healthcare, not only for Microsoft but around the big tech, we'll get it right. We have a lot to learn and come to this space with humility as a technology company to learn from our colleagues in healthcare and medicine.
Thank you for that perspective. Absolutely. So Greg brought up this very important word of trust again to the conversation. I'd like to bring that back to you, Rahul. When we think about trust, and you're developing AI algorithms for the social good, and for these really high stakes questions like health, where sometimes the very small circle of trust for people with such things that so personally impact us. What will it take for someone to trust, let's say, an AI algorithm with their life, and what can AI do to earn that trust in the way that you see it?
Well, to start with, I don't think AI is at a stage where anyone should trust their life with it. The trust, it's such a small word, but it's also a very big word. Right? So it's useful to unpack this a little. I think of this as sort of, you have to look at who needs to trust, what do they need to trust, and and how do you engender trust. So who needs to trust? For example, I gave the example of our visual weighing machine. Is it the mother who then has to take remedial action and whose baby it is, and therefore has to panic or not panic? Or is trust needed from the ASHA worker who is actually taking the action and giving the advice of and therefore who is a member of the community and whose credibility with the community depends on the quality of her advice? Is it the A&M who supervises the ASHA and therefore has to make sure that she's doing the right thing? Is it the district health official or the state health official who is interested in making sure that the numbers actually improve and look right? Or is it the likes of the national programs or the Bill and Melinda Gates Foundation who actually fund these rollouts and fund and actually enable these rollouts? All these players need different things. Their interests are different, and therefore what's needed for each of them to trust are very different. And I'm not even going into what kind of trust is needed for regulatory approval. Right? That's a whole other thing. So yeah, who needs to trust? Complicated question. What needs to be trusted? There's many of the commonly known things of, some of these are black box models, and so you don't quite know why it's actually giving a particular inference. Also, you also need to trust what's the quality of the data going in to actually generate the inference. Has the action been right? But I'll give you maybe another example that's come up. Let's say it's this low birth weight thing that we're doing. You can think of it as a screening solution, which is we want to make sure we don't miss out the low birth weight and very low birth weight babies, and a few extra normal babies getting caught in this is okay if it's a screening solution. In which case you optimize for recall over precision. On the other hand, at the district and state level, what they care about, what you want is roughly equal number of false positives and false negatives, because they're trying to estimate the total incidence of low birth weight and asking, well, is the nutrition program having effect, right? And so they don't want over-reporting of numbers and playing it safe. So you may have competing priorities even on what it is that you're trying to engender trust in, right? And then there's of course the how. And for the how, I'll pick again, there's the obvious ones about the how are of course interfaces and confidence measures and things like that. I'll give a real example from the adherence work we're doing. We're trying to predict if a patient is actually likely to fall off adherence, right? But what's the action from that prediction? You're trying to guide the TB health visitor to take preemptive action. Now, if the preemptive action is taken correctly, no one's going to fall, or very few people are actually going to fall off adherence. So how do they know, how does the TB health visitor know that what they're doing is useful, right? Because they never see the downside of not doing it. How do you engender trust in something where the downside is never seen? Of course, at the system level, you can do A/B testing and things like that, but you can't keep doing. So what's instant gratification for a TB health visitor?
You might argue vaccination is similar
to
that in a way.
That
we've forgotten what it was like before that came along.
Yes. So sum total is one syllable, but it's a big word.
Absolutely. Thank you for that perspective. And kind of the hierarchical nature of that trust, that often people are making decisions on behalf of many others, and it's their trust and their beneficiaries' trust enveloped there. Do you have something to add?
Yeah, I was going to disagree. I think.
Please.
Please do.
Rumble.
I'm going to say that AI is ubiquitous around us already, and we already Or I know I did when I traveled here, trusted my life with AI. When I took my flight into town, it was foggy and landing, and I'm positive the AI landed that flight rather than my pilot to do that. I'm
H-infinity control.
Yeah. What we haven't done is, and I wouldn't advocate for, is removing the human from the loop. So whether it's my driver that's using some part of self-driving, or myself, I think we're still comfortable with someone in the driver's seat. We still want someone in the cockpit of the plane to do that. And I think when it comes to a nurse or a physician or a healthcare worker in a village, using that, I think we want that human piece of that. Healing and medicine is intensely human, and particularly that relationship, that touch, that complex decision making that's needed. So that's my disagreement here. So
Good. Please, yes, Victor. Do we have a mic?
No, it's just a small comment. Can I just disagree with you?
Okay.
And say that what you cited as AI.
We need the mic. Yeah.
What you cited as AI in a cockpit, I actually experienced that too, by the way. I was also sort of like, wow, this is cool. But that's not. I don't think of that as AI at all.
Yeah, I know there's
right? The only reason I bring that up is because sometimes it's sort of like, I sort of agree with you that, I'm also very heavily into tech, and I don't have the trust that you're talking about, because the things that we have solved are not, that we are now okay with, they are not AI. I mean, we should be very clear about that.
Yeah.
Like how they are built out, but they're all like now, because of the AI cloud, everybody talks about it as AI.
Yeah,
That's
thanks for the comment. And I've even seen decision support trees be called AI in the earlier things. So I was using that broader definition, but thank you. Yeah.
We could probably get into the definition of AI.
Oh, that's a lost cause if we start trying to.
One more from the audience, and I'd like to hear it from Beena on trust. But yes, please.
So I have two short questions. So one of them is about the human.
Yeah.
The human and.
You can speak up, maybe.
We don't trust the mics. So the human in the loop thing, right? I mean, to what extent do the humans in the loop become like this fig leaf? Just that I have somebody to blame when the AI healthcare system fails. Well, the doctor should have checked it, but if 99.9% of the time that system works fine, and then for that one time it misdiagnoses, then you say, oh well, it's the doctor's fault, right? And then I mean that sounds somewhat unfair or somewhat broken. I don't know. I don't know enough about it. I would like to hear your thoughts about that.
Yeah, maybe I'll just give you a quick example why I wouldn't want to remove a physician in the loop. So think of a hypothetical AI algorithm that said treatment was futile for an advanced breast cancer. It will never be able to manage the relationship that mother wants to make it and go through a pretty significant and severe treatment and complications to her daughter's wedding, to her grandchild's birth. And these are intensely human conversations to be had between a patient and her or his caregiver. And so this is why I don't want to, just one example, we can give many, that why I don't want to remove a human from the loop here.
Yeah.
I have two things to say there. One is, with human in the loop, is the human checking the AI, or is the AI checking the human? Or is it both?
That's the point. I mean, sometimes it gets.
And
sometimes it gets inverted, right? So that's the point. Right?
Actually, that's not a bad thing, right? That's not a bad. In fact, it's just important to be deliberate about it. And our current evidence shows that these sort of centaur systems, right, part human, part machine, actually are better than purely algorithmic or purely human. The second, and so it's just useful to be deliberate about which way it is, and maybe the check runs both ways, by the way. And the second point I'd make is, one very important reason we still need human in the loop is because we, all our algorithms, virtually all our algorithms today are based on correlational reasoning. They don't have any causal reasoning in them, right? And there are any number of famous examples of spurious correlations being caught, suggesting absurd actions, right? I mean, I can give any number of examples, but we know these. And so they may For those though, there might be a time when our algorithmic capability catches up, right? But and at that point we can revisit the central question.
Great. So I'd like to bring this conversation back to you, Beena, in terms of trust.
Yeah.
Often from patients' perspective, especially lower income patients or patients that are less educated, that's a real leap of faith to trust many different things in the system. What technologies have you seen? Technologies that have earned patients' trust or earned too much of their trust? How do you think about trust in the work that you do?
First of all, I don't even think there's a debate between the human touch and technology. I think one just cannot do with the other. What earns patients' trust? I think digital literacy itself is not there. Like even before we go into some kind of technology, how much do we really invest on promoting digital literacy among, especially the community when we talk about the diseases such as TB or HIV among the lower socioeconomic, they don't even have a clue about what it's about. And again, quoting from 99 Dots, there's this beautiful dashboard which has, information on whether, a person has taken the treatment, which shows green, and if he or she has not taken it, it's red. The sad thing is, there is no time invested on even explaining to the patient that there is something like a dashboard. So when we show patients that this is it, their eyes open up. But whoever takes the time, so without that human interface, and it's come to a stage, even now, take any human interaction within families, it's all through your WhatsApp or your phones, everyone wants information to be translated through or transmitted through these different gadgets, but never, human interface where, touch is so important. I don't think digital technology can ever replace that touch. There was a beautiful book written by Abraham Verghese who says, doctors spend 60 seconds per patient. Then what about the other healthcare providers? Or maybe you just say, you're going to take this, all you have to do is technology will take care, everything, or AI will diagnose. I mean, there's nobody who even talks to them. There's no looking into eyes. There's no, it's sad, even you go to restaurants these days, 4 people are going, the parents, and what are they doing? All 4 with their cell phones. Nobody wants human interaction anymore. So I think this whole thing in healthcare especially, how important it is for that look into the eyes, touch, care, and then you bring in any technology, I'm sure it would work.
And I think, really important part about what you said is there's sometimes that asymmetry between, the provider's view could see all of the details and why someone should trust this, but, unless that is openly communicated transparently, that trust would never come back. And I had a question for the technologists here in terms of thinking about that communication, in terms of our understanding of trust and the difference between perceptions of trust and kind of reality of trust, that oftentimes the system that might be the most easily saleable as trustworthy is different than the one that actually maybe really is the most trustworthy. And to take one example, we're seeing often now in global public health, often conversations around the importance of hosting patient data in country, for example, even in very low resource countries, that there's certainly the perception by many people that keeps it safer because it's amongst trusted local entities, for example, that are either trusted by the government or the local players. And, of course, in many respects, those same systems, especially in the lower resource areas, are not as technically mature, let's say, or as brutally attacked in other contexts to have the robustness of, let's say, a global cloud infrastructure and so on. So how do we bridge that gap between what is, what we believe perhaps on this stage is the most trustworthy and what others in certain contexts may have good reason to perceive as being less trustworthy? How do we approach that conversation?
Sure, I can perhaps start there. So it's the baseline that you look at right now in the U.S. alone, over 2/3 of individuals, the population's healthcare records have been breached in the last few years. So and that isn't too much different anywhere around the world. They've been breached through healthcare plans, healthcare systems. If you think about where the technology is in those healthcare system. It's a data center with a staff of an IT staff of just a really skeleton IT staff. It's not the core competency to protect data. Meanwhile, you do have a large enterprise player, the public cloud, that brings hundreds, actually thousands, at Microsoft and the other tech companies coming and bringing enterprise scale security, more sophisticated than most nation states can do. And so the real ability to protect data and earn that trust is, how can a healthcare system, how can a small NGO leverage these large public scale enterprise services, and a part of that is they remain, they get their own instance in a public cloud, but they hold the encryption keys to that. So even if there was malintent anywhere there, that'd be actually impossible for someone at a tech company actually, it's impossible that it gets to even look at that data there. So I think it's an educational issue to say, and even a policy issue. I think it's a government scale. How can a country, how can an organization maintain sovereignty over their data? Perhaps that sovereignty should be defined as holding the encryption keys to that data while doing the responsible thing to use the best possible technology and resources and minds to actually protect that data at an enterprise grade scale. That's one view. I think we have a lot of policy to do that.
Thank you, Greg.
At least they know that in the US. I think in India they wouldn't even know if it's been breached. And I just have a question again, saying that for AI, for example, now you predict those at risk, whether it's for cancer, then of course, or anything, then insurance companies get to know. We discussed that earlier, and there goes, their chances. Or if you take TB, now these are at risk for people who will not comply to treatment or who would not use technology, and they are branded as risk, groups. How do we get over those kind of issues where sometimes you use all this to predict, but at the same time it might be indirectly stigmatizing them, and you can say preempt intervention, but why me? Why should I haven't done anything as yet, but already I've talked about, like, I am a potential, person who's going to be a non-compliant or will not use what
vulnerable population, right? Yeah. Vulnerable population.
Vulnerable, high risk. These are the kind of terminologies used.
Absolutely. So which of our risk factors should be private if they're, inferred from things that, in a way that we wouldn't anticipate, are inferable? Absolutely. Well, did you have something to add?
No. Well, I did. On the security thing, again, Greg covered most of it. This is the one thing I'd add is it's also a legal issue, which is laws are defined in the territory of nation states. And so how do you actually govern data that does not physically sit there? And in many cases, these laws are still being enacted, right? Some of these bills sit in parliament in many countries. So that's one part. And then secondly, once these laws are enacted, how is it supposed to be enforced? Do the governments have the technological capability to do the necessary audits to find out if data sovereignty is being maintained? So in many cases, I think it goes back to the capabilities of the governments involved.
If I can add a comment, so certainly a lot of work to do on the regulatory front. But going back to the risk, I couldn't agree with you more. What I haven't seen is a robust discussion on balancing of risk versus good, and I think we often will talk about even hypothetical risk, and even us as scientists, physicians are often first to raise, what is the hypothetical potential risk, and for good reason. I've come now over the years, so I'll just take an example back to the start of the Human Genome Project, where it was put out, what if this information is so rich, so valuable, says so much about me? What if hypothetically an insurance company or my employer got a hold of that data, and I was denied a life insurance policy or even a promotion because, say, you might be at risk for early onset dementia that's found like with the ApoE gene in your code, and so that hypothetical risk that was laid out there scared millions and millions of people. So fast forward 10 years from that, and I was at Geisinger Health System, and we had a MyCode project which was doing sequencing for patients there. And many people were scared, what if this information, where is the information is there even as you go through a consent project? And that's a very successful project, 92% of the people consented, but even that 10-year delay of that hypothetical risk actually resulted across the US, and this is the globe, tens of thousands of women dying of breast cancer because they're afraid to be sequenced for the BRCA gene. So this is a really real risk that versus these hypothetical risks that we have to balance. And I think as scientists, physicians, I think it's, I've become, much more careful about when I lay out a hypothetical risk, actually, also being sure that I the best that I can and know to talk about the really real risk of not using that data. So it is about balancing privacy with individual and even public good.
Thank you, Greg. I'd like to open it up. Any provocations, questions from the audience? Yes, please. Mike. No, I'd like to take it from the woman as well. Yes, please. While the mic is going, please. Yeah.
All right. Thanks very much. This is really, really sort of enlightening. I'm going to start with Rahul, your stuff about, you said sharing saving the mesh model on the phone. Very often the data which you collect is not very interesting. It's the metadata which actually reveals a lot. This is the bad mic? Right. So one is that was an observation which the metadata about where it was collected, when it was collected, how it was collected is often much more revealing.
Right.
And a lot of privacy related stuff goes there. Beena, thank you very much. And let me just give you an
by the way, I can give you a cop-out view on that.
Okay, I just want to so this is from experience where I was called in to sit in with the National Mission for Hepatitis, which is a stigmatized disease. And what was very interesting was the doctors from the ministry who were talking to me were absolutely, saying, please, please, please make sure that nothing goes through which will reveal, data about the patients. Whereas the tech companies which were coming in and talking to the government, because they were selling their product to the government, were very proud of this panopticon view they had. They could, they were very, our dashboard shows you exactly which house, which patient in, which locality has what form of hepatitis, and very often HIV as well, because sometimes they're comorbid. And this was, one of the strange things. So the tech companies, one of the things which I would say is that they find it very easy to sell privacy-breaking software or things which is sort of expose the patients when they're selling to the governments. And on the other hand, their products which have to deal with private consumers tend to be quite nice as far as privacy goes. So this is something, just two observations.
No, the comment about the metadata, very valid. I said the cop-out answer is that, for example, in our case, many of these models that we are deploying, we are not creating new apps. We're embedding them into existing mHealth pipelines. So we release SDKs and actually integrate into existing apps. So the metadata is already coming into the cloud, right? That's why I said it's a cop-out answer.
Privacy is already lost.
Yep.
Okay, so my question here is do we have a national health database in India? And what are the programs that MSR has that will help the primary health centers at a local level? My second question is, for example, if we have an epidemic like the coronavirus, right? Do you have any programs that will help the government maybe look into which are the targeted areas, which parts could be more affected? and measures that we can do to prevent them.
Good. So what can be done locally at primary healthcare?
Yeah, first
level?
is the primary health care centers, also with privacy in mind.
With privacy in mind and monitoring, for example.
What if we have an epidemic? What is the kind of solutions that you guys offer?
Very good. While we're thinking about this for the panel, next question. Can we move the mic to the next question? All right, please think of some questions, guys. Any comments on that, guys?
Yeah, like I had said earlier, the sad thing is there's nothing called community preparedness. In the wake of a pandemic like this, we had the Nipah virus, we had dengue. The community is never, prepared for it. Take TB, for example. I work with TB. Now, the Prime Minister has said that we have to eliminate TB by 2030. So you just go into this, mission mode trying to detect cases. So yes, your answer to your question is we have a database, of all the information there is we have the Nikshay, which is supposed to be capturing all the information for TB. So that is, but your next question about, how this is being used, there's hardly any digital literacy or, community sensitization. In terms of a pandemic, that's one of the things which I was saying in a forum. Why is it we don't invest on preparing communities and promoting, literacy rather than, go straight into what should be done? Like isolate people or, you have to be prepared or start working on a vaccine. Already they're thinking, but nobody has told them, how they don't need to panic and what it's all about. And get people influential in the community to be their ambassadors. That never happens. You never prepare communities.
So my question here is, you don't have any technological solutions from
There are no technological solutions from MSR for at the local level, you're saying?
Yeah, the local as well as the global level, like using AI, machine learning, predicting epidemics.
Yeah, maybe I can. So out of Microsoft Next, which came out of MSR, there is a project called Premonition. Project Premonition. You can look at that online, and this is actually uses AI, and essentially it's an AI-enabled field biologist in a robot that goes out into the field, and think about it as a field biologist and with a genomics background, so can do a full metagenomics pipeline by looking at various vectors in the environment, whether it's a mosquito, what the mosquito is fed on, and then to be able to predict where epidemics are likely to come from and also where they spread.
We're not respecting the privacy of mosquitoes.
That's right. Exactly. So there is technology there. Scaling this is an incredible challenge. I think we have ideas how to do that, and even are doing that in some areas now. And rest assured, there's outreaches even in the current.
So you might identify the hotspots or the vulnerable areas again, but then what happens to the people there? I mean, they are never prepared for that.
Yeah, that's a public health. That's equiping the public with the tools.
Take care of that.
Yeah.
Specific to India, there are certainly projects that I'd be happy to discuss after the panel. Some projects that have happened over the years, looking at supporting local health workers here. There is a line of work there.
Really fantastic work.
Thank you for the question. Maybe a last question from the audience? Or is it back in my lap? Oh, please.
Just a short question. So maybe it was the question that was asked from the previous panel. So I will ask you this, because I think that you're probably in a good position to try to give an answer. How would you quantify these trade-offs, right? So for you, it's a very real trade-off when you say, okay, we want to make our AI more trustworthy at the cost of accuracy, right? So that's a very real thing. That means that you're going to potentially misdiagnose somebody, and that might come in the cost of lives and time, and which translates against two lives. So how does that work? So how do you make these decisions, and then how kind of, if you can walk us through a little bit of the deliberation that goes there?
Well, sorry.
Yeah, there's multiple. There's multiple views that can be taken there. First is the view of regulatory approval. There's a minimum performance needed against claims you make for something to be valid as a screening test or a diagnostic test and so on. Second is you benchmark it against status quo, right? What's happening today, and can you do at least as well, if not better, right? Because the fact is that today's day, in virtually every test being done today, there is a false positive and false negative rate, right? So the third lens you can apply is that of a public health system. To say, for example, if I am developing a screening solution for TB, let's say, what is the today there's a screening pipeline for TB. Starts with active case finding in a home setting, doing symptomatic screening, giving the person an X-ray voucher, go get an X-ray, and then from there going on to a confirmatory test. If you look at the number of people who are screened to finally detecting a patient, you can work out a cost per TB case found. And you can ask the question of, with a new test that is integrated into a pipeline, a new test doesn't stand in isolation. That new test has to be integrated into a new pipeline. And then you design that new pipeline and ask, will the new pipeline bring me a significant reduction in cost per new case found? These are different views that can be taken on assessing, therefore, what's, do you have something useful or not?
Yeah, really great insight, and maybe I would add here is that what you're pointing out is that there's this tremendous sense of urgency, right? There's 4 billion people on the planet without meaningful access to care. There's no way we're going to train enough community care workers, nurses, doctors to handle the need that's very real. We're in the midst of worldwide epidemics of tuberculosis, HIV, malaria, and infectious disease, which we're all wondering about right now. So the urgency is clear, and it's right there. What I worry about sometimes is that there's a bias for technology, and whatever we throw at these really urgent global imperative needs is actually going to make a meaningful, positive difference. And why I'm glad we're at a university today is because I'm going to say there's no shortcuts for actually proving that out with the methods that we have are tried and true. Can we accelerate those? Can we test an intervention, whether that be AI, prove that it makes a meaningful, positive difference, and then bring it forward? We shouldn't assume just because a great tech company or a great startup shows positive progress in a small early samples that's going to prove out in a larger population. So we need to do that with a sense of urgency, but we need to take it through the scientific method as well.
I'd like to say something that we did a project on targeted intervention for TB, and so this time the van was equipped with digital X-rays. So that's when I really realized the value of AI. The reason being that these X-rays were taken, so that was solved, but then who was to read it? We didn't have, there are no doctors who are equipped to really read these X-rays, and there are such varied opinions of what's a positive and what's a negative X-ray. We found there was almost a 64% jump in X-ray positives. So that, again, based on what the doctors felt was positive, whoever read it. Now, I was really worried. How can they be? Now, are they being overdiagnosed, overtreated? So what are we doing? So then when this whole concept of AI, for radiology, I was just thinking to myself, perhaps that was going to be the answer. Now you find everyone is working on this particular aspect. So there are certain things where you look into accuracy. You have to weigh one against the others. Is it that you're going to have the subjective opinion of different doctors, or AI, which is again, which is proved effective? So I'm a little convinced about that part of it, and again, with the human interface. So, yeah.
Thank you, Beena, for bringing that up. Actually, Greg, I have to bring you in here as a trained and practicing radiologist. Even broader than security and privacy, what's your take on AI-enabled radiology?
Yeah, for this, so I love a quote from my colleague at Stanford, Kurt Langlotz, that says, radiologists who don't use AI will be replaced by radiologists that do. It's really, I see AI as a key enabling tool to actually get through that number of cases and scale that and flag those that may need individual attention. I think in the area of TB and chest x-rays and AI, it's looking pretty good. Again, I want to see the study in Nature and Science and New England Journal that validates that, so we can be sure that we're doing no harm and that the data included there is across populations and we've taken into account the potential biases there. I'll say a specific, so I'll tell you what happens at the human interface. So at another health system at Geisinger, where I was leading a radiology department, I had a new radiologist that actually had come from one of the best hospitals in India, and impeccable credentials and trained, but he came from India to central Pennsylvania. So, and the first night that I had him on call, I got a call from the emergency room that said that there were 5 cases of tuberculosis diagnosed that night. Now, the pattern that he was seeing would be the same pattern he was seeing at his hospital in India. It was a community-acquired pneumonia that looked like TB, but it was really about incidence of disease. So the human interface didn't take into account the incidence of disease locally. So AI can be fooled there too, is my point, if you don't actually supply it the right data and the right geo and the right incidence, because you could get it very wrong if you don't include the right data.
Absolutely. So the data in impacts the decisions out, even if it's a human
That's right.
instead of an AI. Yeah. Very good. So our time is almost up. I thought I might just wrap down the panel with a parting thought from our panelists, maybe. One thing to keep in mind, what we're all trying to achieve, not just with security and privacy, but the potential of AI and the limitations in contexts like health. Is there one thing you're excited about and maybe one thing that you're nervous about when you look into the future of using technology and AI in the context of healthcare? Briefly.
I'm an optimist,
okay.
And so I think that AI is going to enable us to actually address those 4 billion people on the planet without meaningful access to care and scale that. I think we have work to do, and we need to do that work with urgency.
Similar vein, I do what I do because I am an optimist. And in fact, I think to solve the healthcare problem with the shortage of trained doctors we have, there is no other way but technology.
We need to bring balance to the force here. Would you like to?
No, so I would say yes, it's important, but I just dread to think of a time where digital technology controls everything. Where doctors no more need to go to the field, no more need to go to clinics. Sometimes I wonder if they even need to go to college for 7 years if it's going to be all dictated by digital technology. So I would say the importance of balancing the two, and like I said, that human touch is most important. And I gave you the example of the X-ray, challenge that we had. So AI has, a great potential, but we need to balance the two.
A wonderful note to close, the importance of keeping the humans in the center of everything that we're doing. Thank you very much to our wonderful panelists and for the questions from the audience.
Thank you, Bill. Thank you.